Welcome to the Concierge Care Health System podcast. The information shared in this podcast is for general informational purposes only and does not constitute medical advice. Listeners should be aware the content is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a physician or other qualified healthcare provider for medical questions.
Usually, when we talk about a medical diagnosis, there is this baseline expectation of absolute precision.
Right, like a binary yes or no.
Exactly. You break your arm, the x-ray shows that jagged white line, and the orthopedic surgeon just points to the screen and says, well, there it is, it's clean.
But the moment you step into the world of neurodevelopment, that x-ray machine is, frankly, fundamentally useless.
Yeah, it completely falls apart. We find ourselves navigating this diagnostic landscape that is just astonishingly murky, and we are plunging straight into that complexity today.
We really are. We have a lot to cover.
Welcome to the deep dive. Today, we are taking a single comprehensive source, which is this massive, data-dense clinical review document.
It's titled Clinical Review of Attention Deficit Hyperactivity Disorder, document number NUR 00000004122507001.
A very catchy title, I know.
Yeah.
But the mission of this deep dive is to completely deconstruct ADHD. We want to move way beyond those tired, simplistic cultural stereotypes of, fidgety kids who just can't sit still in a classroom.
Because that stereotype is so damaging.
Yeah.
We're going to explore the literal hardware of the brain here.
Right. The hardware, the intricate diagnostic mazes clinicians have to navigate, and the deep societal implications of how we treat or completely fail to treat this condition across the human lifespan. So, okay, let's unpack this.
Let's do it.
Because to truly understand the modern clinical view of ADHD, I feel like we have to look backwards first. There is this persistent cultural myth that this is some modern pathology born out of, like, the smartphone era.
Oh, yeah. The idea that it's a byproduct of TikTok and endless scrolling, that is one of the most pervasive and, frankly, most damaging misconceptions we encounter.
It really is everywhere.
It is. But the medical literature actually contains highly detailed descriptions of behaviors we would instantly classify as ADHD today, stretching back well over 2 centuries.
Wait, 2 centuries?
Yeah. And what is critical to note is that even early on, some really astute observers recognized these differences stemmed from the nervous system.
Mm-hmm.
They weren't just writing it off as a moral failing.
Or like a lack of intellect.
Right. But the formal categorization within modern psychiatry was agonizingly slow. If you look at the DSM-2, which was published back in 1968, the condition was formally termed hyperkinetic reaction of childhood.
Hyperkinetic reaction. I mean, it sounds like a comic book superpower gone wrong.
It really does.
But the most revealing part of that 1968 label is the phrase of childhood, right? The prevailing medical dogma of the mid-20th century was that this was strictly a pediatric issue.
Yes, the establishment operated on this assumption of spontaneous remission. They genuinely believed that once a patient hit adolescence or early adulthood, the brain simply corrected itself.
Like it just magically grew out of it?
Exactly. The physical hyperactivity seemingly vanished, so the assumption was that the underlying neurological divergence had just resolved.
Which is a fundamental misunderstanding of how the condition merely changes shape over time. But even before that 1968 classification, the source highlights this incredible moment in 1937 involving a physician named Dr. Charles Bradley.
That is a fascinating piece of medical history.
Most of you listening probably already know that stimulants are the first-line pharmacological treatment today. But looking at how we arrived at that treatment is a fascinating study in backwards medicine.
Bradley's work is a classic example of empirical observation leaping decades ahead of mechanistic understanding. He was working with children who exhibited severe emotional instability and drastically short attention spans.
Behaviors that were largely attributed at the time to minimal brain damage, right?
Yeah, and he administered benzodrine, which is a stimulant, but he originally intended to treat severe headaches resulting from these invasive neurological procedures.
So he wasn't even trying to treat their attention or behavior at all.
Not at all. But what he observed, entirely by accident, was a dramatic, paradoxical, calming effect on their behavior and a massive improvement in their academic performance.
It's wild. It perfectly illustrates the messy reality of clinical science. They found a chemical treatment that worked decades before anyone had the tools to understand the underlying neurobiology of the disease.
It was a complete accidental breakthrough.
It is essentially like trying to fix a sluggish car by randomly pouring a new fuel additive into the gas tank, watching the horsepower suddenly double, but having absolutely no idea how a combustion engine actually works.
That's a great way to put it. You have the key, but the lock is completely
Oh,
undeadable.
yeah, easily.
And that pharmacological empiricism drove the treatment protocols for the next half-century, while the diagnostic manual slowly played catch-up. By 1980, the DSM-3 introduced attention deficit disorder.
Which finally officially recognized that the cognitive aspect, the attention deficit, was the core issue, not just the physical hyperactivity.
Right, but the most monumental shift, the one that completely redefined the clinical framework we operate in today, occurred with the DSM-5 in 2013.
The DSM-5 reclassified ADHD as a neurodevelopmental disorder. It pulled it entirely out of the category of disruptive behavioral disorders.
Which is huge.
Yeah.
By categorizing it alongside conditions like autism spectrum disorder, the psychiatric community formally acknowledged that ADHD is rooted in the physiological, biological maturation of the brain.
It's a structural and chemical divergence.
Exactly. This wasn't just a semantic update. It was a paradigm shift that legitimized the lived experience of millions. It stated unequivocally that the executive dysfunction associated with ADHD is not poor parenting or a lack of discipline.
But the DSM-5 also made some highly specific and honestly somewhat controversial tweaks to the diagnostic criteria. They pushed the required age of onset back from before age 7 to before age 12.
Yes, and they broadened the definition of the impact. Previously, there had to be evidence of impairment, but the DSM-5 changed it to require that symptoms simply be present.
And I want to push back on that specific change for a second. If we are no longer strictly requiring these symptoms to be visibly ruining someone's life, causing severe impairment, and we just require them to be present, aren't we lowering the bar?
Lowering the bar how?
Well, aren't we risking pathologizing normal human distraction, especially in a modern environment that is literally engineered to be maximally distracting?
This raises an important question, and it is the exact locus of the overdiagnosis debate within the psychiatric community right now.
I imagine it's highly debated.
Oh, fiercely.
Yeah.
But the rationale provided in the clinical review is rooted in the historical failure of the previous criteria. The old visible impairment mandate was leaving a massive, silent demographic completely undiagnosed.
Who was it leaving out?
Specifically, it was filtering out highly intelligent individuals or those with really structured support systems. These patients learned to aggressively mask their symptoms.
Oh, I see. So from the outside, there was no catastrophic impairment. They were passing their classes, holding down jobs, maintaining relationships.
Right. But internally, the cognitive load required to maintain that facade was completely unsustainable.
So they were basically paddling furiously underwater just to look like they were floating gracefully on the surface.
That's exactly it. The effort required to constantly compensate for severe executive dysfunction secretly drains a patient's cognitive and emotional reserves.
It must be exhausting.
It is. By shifting the criteria to focus on the pathological presence of the symptoms, rather than just the outward societal failure, the diagnostic net was recalibrated. It now captures those who are suffering profound internal distress, even if their coping mechanisms prevent immediate outward collapse.
Okay, that makes a lot of sense. And if we look at the raw epidemiological numbers, that recalibrated net is capturing a staggering amount of people globally.
It is. The global pooled prevalence estimate for children and adolescents is 7.2%.
Wow.
Yeah, when applied to global population metrics, we are talking about roughly 129 million children worldwide.
That is a massive scale. But the truly fascinating data emerges when we look at the adults, exposing that huge historical blind spot we talked about earlier. We know that 1968 assumption of spontaneous remission was totally false.
Completely false. Current longitudinal data indicates that 40% to 60% of children diagnosed with ADHD continue to experience clinically significant impairing symptoms well into their adult lives.
I actually want to pause and ask you, the listener, directly. Have you ever felt like you were just fundamentally bad at adulting?
It's a common feeling.
Right. Like everyone else was handed this hidden instruction manual for organizing their finances, remembering arbitrary appointments, and initiating incredibly tedious tasks, and you somehow just missed the memo.
Because when we look at the adult data in this clinical review, it becomes clear there is often a very real, measurable, physiological reason behind that feeling of constant friction.
And the source material categorizes the adult data in a very revealing way. It distinguishes between persistent adult ADHD and symptomatic adult ADHD.
What's fascinating here is that persistent adult ADHD refers specifically to individuals who met the full, rigorous diagnostic criteria in childhood and whose symptoms have unbroken continuity into adulthood.
And the global prevalence for that highly specific group is what, about 2.58%?
Exactly. But then we have symptomatic adult ADHD, which captures adults who are currently exhibiting clinically significant symptoms, regardless of whether they had a documented formal childhood onset.
And the prevalence for that group jumps to 6.76%. That gap between 2.58% and 6.76% is massive.
It really is. It statistically proves that millions of adults are currently suffering from severe clinical symptoms right now, even if they completely slipped through the cracks as kids.
Probably because they had the inattentive presentation that didn't disrupt the classroom, or because they were high masking, like you mentioned.
Exactly. But identifying these adults clinically is incredibly fraught because, as the text points out, there are no universally validated diagnostic criteria specifically designed for adults.
Wait, really? None at all?
The whole diagnostic framework was built around pediatric presentations. So when doctors try to apply pediatric criteria to a 45-year-old executive, the translation just fails.
Because adults don't typically run around climbing on furniture in a boardroom?
Right. Because we lack validated adult-specific tools, clinicians lean heavily on what the field calls clinical wisdom.
Which is a polite way of saying the diagnostic process becomes dangerously subjective.
It's very subjective. Depending on the specific bias of the clinician sitting across from you, your identical set of symptoms might yield an ADHD diagnosis, or a generalized anxiety diagnosis, or just a dismissive lecture about needing to utilize a better calendar system.
And the cost of that diagnostic failure is catastrophic. The text unequivocally links untreated adult ADHD to severe secondary outcomes. We aren't just talking about, misplaced car keys here.
No, the stakes are much higher. We're talking about elevated risks for major depressive disorder, severe financial instability, and devastating impacts on interpersonal relationships.
The review also mentioned a statistically significant increase in the rate of severe traffic accidents.
Yes, because if your neurobiology actively struggles to sustain attention on understimulating, monotonous tasks, driving a vehicle on a straight highway for 3 uninterrupted hours becomes a highly dangerous proposition.
Which brings us to the absolute core of this entire document. If we want to understand why these symptoms stubbornly persist and why they infiltrate every single domain of a person's life, we have to stop analyzing the outward behavior.
We have to look directly at the architecture of the brain. We need to look under the hood.
Exactly. And when we examine the biological reality, the first undeniable factor is genetics. The heritability of ADHD is staggering.
It consistently ranges from 60% to 90%.
Up to 90% heritable. That puts it on par with the heritability of human height.
To contextualize that, first-degree relatives of individuals with ADHD face a 5 to 10-fold increased risk of developing the condition compared to the baseline population.
It is deeply embedded in the familial genetic code. However, the review notes it is highly polygenic. There is no single ADHD gene you can just test for.
Right. Genome-wide association studies have identified multiple significant risk loci, heavily implicating genes that regulate neurotransmitter systems, specifically variants like DRD4 and DET1.
But those common variants only explain a fraction of the total heritability, right?
Yeah, it is a vast, complex interplay of thousands of minute genetic variations combined with environmental epigenetic factors.
So the genes draft the architectural blueprint, but how does that actually manifest in the physical structure of the brain? Because the review details actual volumetric differences.
We aren't just talking about abstract chemical imbalances here. We are talking about the physical size of specific brain regions.
That's wild. What regions specifically?
Structural neuroimaging studies consistently reveal that overall cerebral volume is significantly smaller in children with ADHD compared to unaffected control groups.
Wow.
But the localized reductions are what explain the clinical presentation. We see marked volume reductions in the prefrontal cortex, which is the command center for executive function.
And the basal ganglia too, right?
Yes, the basal ganglia, which is heavily involved in motor control, reward processing, and habit formation.
The review also highlights the dorsal anterior cingulate cortex, or the DACC.
The DCC is essentially the brain's internal error detection system. It monitors conflict and signals when you need to adjust your behavior.
So if that's physically smaller.
When the DACC has reduced volume or impaired connectivity, the individual literally fails to recognize that they have drifted off task or made a behavioral error until it is far too late.
Furthermore, imaging shows a significantly smaller corpus callosum. That's the primary white matter tract connecting the left and right hemispheres.
Yes.
So the main communication cables between the brain's processing centers are physically smaller, which means reduced bandwidth.
Reduced white matter volume translates directly to altered myelination. Myelin acts as the insulation around neuronal axons. If that insulation is compromised, the speed and efficiency of neuronal communication drop drastically.
But perhaps the most profound structural revelation in the source material relates to the actual timeline of cortical maturation. Here's where it gets really interesting.
The data shows a massive delay in the peak density of gray matter. In a neurotypical brain, the thickness of the cortex where the actual neuronal cell bodies reside peaks at a certain developmental stage before the brain begins pruning unnecessary connections.
To increase efficiency, right?
Exactly. But in individuals with ADHD, this peak cortical maturation occurs approximately 3 years later than in healthy controls.
3 entire years of developmental lag in the prefrontal cortex. Let's think about the mechanics of that. I want to upgrade an analogy here.
Okay, let's hear it.
It's not just like baking a cake where you take it out too early and the center is gooey. Think of cortical maturation like laying down the fiber optic infrastructure for a massive city.
Okay, I like this.
If the physical cables, the myelination, the gray matter density are still being actively laid down in the prefrontal cortex, the software of executive function, impulse control, and future planning literally cannot run at full speed.
You cannot run gigabit internet over unfinished copper wire.
Exactly. If a 10-year-old child physically possesses the prefrontal executive infrastructure of a 7-year-old, the hyperactive and impulsive behaviors aren't intentional defiance.
No, they are a direct output of the available hardware. That captures the mechanical reality perfectly. You cannot use punitive discipline to force a prefrontal cortex to mature faster.
You just can't. And the source introduces a deeply compelling concept here called endophenotypes.
Yes, these are measurable, objective neurobiological deficits that bridge the gap between the genetic blueprint and the outward behavioral disorder.
So these are like the hidden physiological signatures of the condition?
Exactly. Researchers studied unaffected first-degree relatives, siblings of ADHD patients, who do not meet the behavioral criteria for the disorder themselves.
So outwardly they appear completely neurotypical.
Right. Yet, when subjected to rigorous neuropsychological testing, these unaffected siblings demonstrate measurable subclinical deficits in working memory capacity, processing speed, and response time variability.
That is incredible. So they inherited the subtle neurological processing delays, the endophenotypic signature, even if their specific genetic and environmental combination didn't push those deficits past the threshold into a full clinical diagnosis.
It proves how deeply woven this structural reality is within the family tree. And layered on top of this delayed structural maturation is a profound dysregulation of the neurochemical environment.
Specifically involving dopamine and noradrenaline. The review zeroes in on the dopamine active transporter, or DAT.
The dopamine active transporter acts as the brain's vacuum cleaner.
Okay, a vacuum cleaner.
Yeah. After a neuron releases dopamine into the synapse to transmit a signal of reward, motivation, or focus, the D clears the dopamine away to reset the system.
So what happens in an ADHD brain?
In ADHD, genetic and imaging studies suggest the DAT density or function is abnormal. Often, the transporters are clearing dopamine out of the synapse way too quickly, leaving the brain in a constant state of dopamine deficit.
Which perfectly explains why the pharmacological treatments work the way they do. They aren't generic sedatives designed to numb a hyperactive child.
Not at all. They are highly specific mechanistic tools. Melpharidate, a primary stimulant, acts precisely by blocking those dopamine transporters.
So it basically jams the vacuum cleaner.
Exactly. It jams the vacuum cleaner, allowing the extracellular dopamine to remain in the synapse longer, finally providing the prefrontal cortex with the chemical fuel it needs to sustain attention.
And we see similar specificity with non-stimulants, right?
Yes. Atomoxetine, for example, is a highly selective norepinephrine reuptake inhibitor. But what is crucial to understand is that in the prefrontal cortex, dopamine transporters are incredibly sparse.
Oh, really?
Yeah. In that specific region, dopamine relies on the norepinephrine transporter to be cleared away. So by blocking the norepinephrine transporter, atomoxetine effectively increases both noradrenaline and dopamine precisely in the prefrontal cortex.
Without flooding the rest of the brain's reward pathways with dopamine.
Yeah.
Which is why it lacks the abuse potential of a stimulant.
Exactly. It's a very precise chemical key.
So we have a condition defined by massive heritability, polygenic risk loci, delayed physical cortical maturation, reduced structural volume in error detection centers, and specific neurotransmitter transporter dysregulation.
It's a massive amount of invisible biology.
Right. If the root of the condition is this microscopic, this intricate, how on earth is a clinician supposed to accurately spot it during a standard 45-minute office interview?
It explains why the diagnostic process is such a minefield. It is a staggering clinical translation gap.
Because the clinician cannot easily image the DACC or measure extracellular dopamine levels in a standard clinic.
No. They are forced to rely on the outward behavioral symptoms, which are categorized by the DSM-5 into 3 primary subtypes, predominantly inattentive, predominantly hyperactive impulsive, and the combined presentation.
And to try and capture that adult presentation we discussed earlier, the DSM-5 lowered the symptom threshold for older patients. Children require 6 core symptoms from either the inattentive or hyperactive domain, but for adults 17 and older, the threshold is only 5 symptoms.
And those symptoms must be present across multiple environments, like work and home, but the core vulnerability lies in the assessment tools themselves.
The subjective questionnaire.
Exactly. The standard practice relies heavily on clinical interviews and subjective behavior rating scales. You're asking a patient, or their partner, to quantify subjective experiences like how often do you feel restless, or how often do you struggle to organize tasks.
But the clinical review explicitly states that these rating scales suffer from poor specificity.
Right. In epidemiology, sensitivity is a tool's ability to correctly identify true positive cases. Specificity is its ability to correctly identify true negatives, ruling out people who do not have the condition.
So a tool with poor specificity generates a high rate of false positives.
Exactly. If you administer a standard ADHD questionnaire to a population experiencing severe sleep deprivation, chronic stress, or generalized anxiety, a massive portion of them will score high enough to meet the threshold for an ADHD diagnosis.
Despite having completely normal neurodevelopmental architecture, which is terrifying.
It is, which is why the review advocates for the integration of objective neuropsychological measures, like the QBTP+, BROS, the Quantified Behavior Test Plus.
How does that work?
Instead of asking a patient if they feel distracted, these tools use computerized tasks to mathematically measure sustained attention. They utilize infrared tracking to objectively quantify microscopic head movements and hyperactivity during a 20-minute cognitive stressor.
That sounds incredible. But I imagine they aren't used everywhere.
No, these objective measures offer significantly improved sensitivity and specificity. But due to cost and training barriers, they are nowhere near universally implemented.
Which leaves clinicians navigating the most dangerous part of the diagnostic maze, comorbidity and differential diagnosis.
This is where it gets really tricky.
The symptoms of ADHD, the restlessness, the emotional dysregulation, the racing thoughts overlap almost perfectly with several other major psychiatric conditions. And the review highlights the terrifying clinical overlap with bipolar disorder.
The reciprocal comorbidity rates are daunting. Studies indicate anywhere from 5% to 47% of patients presenting with ADHD may have co-occurring or misdiagnosed bipolar disorder.
That is a massive range.
It is, and the supreme clinical challenge occurs during a manic or hypomanic episode. The hallmark symptoms of mania, severe psychomotor agitation, excessive talkativeness, distractibility, racing thoughts, they look almost indistinguishable from severe hyperactive impulsive ADHD on a superficial level.
It's a mechanistic paradox. Let's think about it like diagnosing a vehicle that is speeding uncontrollably down a highway. Is the car speeding because the gas pedal is physically jammed to the floorboard?
Which would represent bipolar mania, an immense excessive surge of energy and grandiosity driving the behavior.
Right. Or is the car speeding because the brakes have been completely removed? That represents ADHD, a fundamental lack of prefrontal impulse control and response inhibition.
That's a perfect analogy. The outward observable behavior, the speeding car, is identical, but the internal mechanics are completely opposite.
And if you misidentify the mechanics, the treatment can be disastrous, right? If 75% of clinicians rate current adult ADHD diagnostic measures as poor or fair, how can anyone trust an adult diagnosis right now?
It's a huge concern. Because if a clinician mistakes the jammed gas pedal of bipolar mania for the missing brakes of ADHD and prescribes a psychostimulant, the results are explosive. Administering a dopaminergic stimulant to an undiagnosed bipolar patient can actively precipitate a severe manic episode with psychotic features. Clinicians must meticulously search for the nuanced differentiators.
Like what?
The highly episodic cyclical nature of bipolar versus the chronic baseline of ADHD, the presence of grandiosity, and the specific nature of the sleep deficit.
The document also zeroes in on substance use disorder, or SUD, as the most frequent and devastating comorbidity. What is the precise neurobiological link between the two?
It comes back to the dopaminergic dysregulation of the brain's reward circuitry. Individuals with ADHD exist in a chronic state of dopamine deficit. Their neurobiology is constantly starved for stimulation.
So they are self-medicating.
Exactly. Substances of abuse, whether it's nicotine, alcohol, or illicit narcotics, provide an immediate, massive artificial spike in extracellular dopamine. What begins as an unconscious drive to self-medicate a starving reward system rapidly chemically alters the brain, leading to severe addiction.
And the impulsivity makes it worse, right?
Yes. The profound executive dysfunction and impulsivity inherent in ADHD strips away the patient's ability to evaluate the long-term consequences of drug use, making them significantly more vulnerable to initiating use in the first place.
So, assuming a clinician successfully navigates the subjective questionnaires, avoids the bipolar trap, untangles the self-medication of SUD, and accurately maps the ADHD, they now have to build a treatment architecture.
Which is an entirely new challenge.
And reading through this clinical review, it becomes glaringly obvious that handing a patient a prescription bottle is only a tiny fraction of the solution.
Pharmacology is necessary, but fundamentally insufficient on its own. The review establishes that a multimodal treatment paradigm integrating pharmacology with highly targeted behavioral interventions is the only empirically supported approach for long-term management.
Looking at the pharmacology, we have the stimulants methylphenidate and amphetamine derivatives. The review notes their robust efficacy, meaning they are incredibly effective at altering that dopamine baseline, but they required intense physiological monitoring.
The side effect profile is significant. Because these medications stimulate the central nervous system, we see severe appetite suppression, profound sleep architecture disruptions, emotional blunting or irritability as the medication metabolizes.
And crucial cardiovascular impacts, too.
Yes. They cause minor but persistent elevations in heart rate and blood pressure, necessitating baseline EKGs and ongoing cardiac monitoring, particularly in adults.
For patients who cannot tolerate the cardiovascular load or who have specific comorbidities, the review outlines the non-stimulant options. We discussed atomoxetine's mechanism earlier, but the text notes a very serious caveat regarding its administration.
Atomoxetine carries an FDA black box warning, which is the most stringent safety mandate the agency can apply.
Why did it get a black box warning?
It was issued due to clinical trial data showing a statistically significant, albeit rare, increase in suicidal ideation among pediatric and adolescent patients during the initial phases of treatment. It requires meticulous, continuous psychological screening by the prescribing physician.
So medication attempts to stabilize the neurochemical baseline, but then we move to the behavioral interventions. The document makes a fascinating distinction here. Everyone is familiar with traditional cognitive behavioral therapy, CBT, but the text specifically highlights metacognitive therapy for adult ADHD. Why the distinction?
Traditional CBT was largely developed to treat depression and anxiety. It focuses on identifying and restructuring cognitive distortions.
Taking a thought like, I am a total failure because I missed this deadline, and reframing it.
Exactly. That is highly valuable for the secondary depression that accompanies ADHD. But metacognitive therapy is entirely different. It doesn't focus on what you are thinking. It focuses on how you are thinking.
Because the primary deficit for an adult with ADHD isn't necessarily a distorted worldview. The deficit is the mechanical process of executing a task.
Precisely. Metacognitive therapy is designed to directly address executive dysfunction. It teaches the patient how to build external neurological scaffolding.
What does that look like in practice?
Well, if your internal working memory is compromised, metacognitive therapy trains you to externalize that memory into rigid planner systems. If your internal time perception is blind, it trains you to externalize time using visual timers and strict routines. It is about actively managing your own cognitive processing deficits.
And when we look at innovative ways to build those processing skills, the review ventures into emerging tech, specifically digital therapeutics, or DTX. This section is wild. It details an FDA-authorized intervention called Endeavor RX, which is quite literally a prescription video game.
It is authorized as a medical device for pediatric patients. It isn't just entertainment. It utilizes a specifically engineered gamified interface to force the brain to rapidly process multiple streams of information.
So it's effectively exercising the neural circuits responsible for sustained attention and interference control.
Exactly.
But the data point that absolutely jumped off the page wasn't just its clinical efficacy, it was the adherence rate. The review notes that EndeavorX achieves a 78% adherence rate, whereas traditional, highly effective pharmacological stimulants hover around a dismal 52% adherence rate.
It's a massive difference.
Why is a digital therapeutic so much better at keeping patients engaged than a pill that instantly improves their brain function?
Because the digital therapeutic is built entirely around the specific neurobiology of the ADHD brain. It leverages continuous, high-frequency, low-level gamified dopamine reinforcement. It provides immediate, tangible rewards for engagement.
And the dosing schedule is different too, right?
Yes, it operates on a microdosing schedule prescribed in small 5 to 10-minute daily increments, so it never overwhelms the patient's fragile, sustained attention capacity.
So what does this all mean? When you look at that 52% medication adherence rate, it highlights the most brutal, almost cruel irony of this condition.
It really does.
The absolute core symptoms of ADHD, severe forgetfulness, an inability to initiate routines, profound disorganization, and a lack of working memory are the exact traits required to successfully manage a daily medication regimen.
It's an inherent contradiction.
The text cites studies where adult adherence drops to an astonishing 12% after just 3 months. It is the neurological equivalent of telling a patient they desperately need their glasses to see, but they have to use their glasses to find where they put their glasses.
If we connect this to the bigger picture, that brutal irony is exactly why pharmacology alone fails. Medication provides a temporary window of focus, but it does not magically implant organizational skills or routine-building capabilities.
As the clinical adage goes, pills don't build skills.
Exactly. You can give a patient the dopamine necessary to focus like a laser beam, but without the metacognitive scaffolding to direct that laser, they will simply hyper-focus with incredible intensity on the completely wrong task.
And that cascade of failure regarding adherence bridges directly into the long-term prognosis data, which is undeniably sobering. Even with our advanced pharmacological tools, the lifespan impact of ADHD remains severe.
The outcomes data is heavy. Compared to neurotypical cohorts, adults with ADHD experience a 57% increase in poor self-esteem and a 73% higher rate of severe social dysfunction.
The data shows highly elevated risks for marital dissolution, involvement in domestic partner violence, and chronic occupational failure.
It's systemic.
But the statistic that is truly haunting is regarding long-term medication use. We assume that if a patient receives an accurate diagnosis and takes a highly effective stimulant for a decade, their life trajectory will mathematically normalize to the baseline.
But it doesn't always work that way.
Yet the review cites longitudinal studies demonstrating that even after 10 continuous years of prescribed medication, individuals may still show no significant improvement in long-term educational attainment or sustained occupational success by age 30 compared to unmedicated cohorts. How is that functionally possible if the medication works?
Because treating the immediate chemical deficit in the present does not erase the compounding interest of historical failure.
What do you mean by compounding interest?
If an individual spends their critical neurodevelopmental years, childhood and adolescence, unmedicated and unsupported, they miss foundational educational milestones. More importantly, they internalize a decade of negative feedback, developing a core self-identity built around being lazy, stupid, or broken.
So providing a stimulant at age 22 levels the chemical playing field for that specific afternoon, but it doesn't retroactively grant them the study skills they never learned.
Exactly. It doesn't repair their shattered self-efficacy, and it doesn't instantly jumpstart a stalled career. They are stepping up to the starting line, but they are starting 20 yards behind everyone else.
Which perfectly explains why the research community is obsessively hunting for predictive biomarkers. If we can bypass the years of trial and error, we can intervene before that compound interest of failure accrues.
Yes, the clinical holy grail is precision medicine.
The review explores utilizing fMRI, pre-treatment volumetric scans of the amygdala and hippocampus, and EEG resting states to predict pharmacological response.
For example, utilizing an EEG to measure the theta to beta wave ratio. Theta waves represent slower, drowsy cortical activity, while beta waves represent fast, engaged, focused processing.
And ADHD brains have a different ratio.
Many ADHD brains show an abnormally high theta to beta ratio. If we can use an EEG to identify that specific electrical signature and correlate it with a known response to methylphenidate, we can prescribe the exact right molecule on day one.
Sparing the patient months of agonizing side effects from the wrong medications. It sounds incredible in theory, but looking closely at the data in the review, there's a massive glaring flaw in the current biomarker research.
The homogeneity of the data.
Exactly. The document explicitly details a severe lack of replication across studies, and more concerningly, points out that these algorithms are being built on incredibly small, highly homogeneous datasets, predominantly consisting of white male children.
It's a huge problem.
How can the psychiatric community seriously claim to be advancing precision medicine if the foundational predictive algorithms are trained on biased, exclusionary data?
You have identified the primary bottleneck preventing clinical translation. The expert consensus within the document fully acknowledges this critical failure. You simply cannot train a predictive neurobiological algorithm on a homogeneous sample of white pediatric patients and expect it to yield accurate, safe, pharmacological predictions for a diverse adult female population.
The neurodevelopmental trajectories and environmental epigenetic factors are entirely different.
Completely different. Furthermore, the infrastructure required fMRI machines and specialized bioinformaticians makes these tools astronomically expensive. Until the datasets are massively diversified and the technology becomes economically viable, these high-tech biomarker scans remain academic exercises.
Practically useless in a standard community clinic today.
Sadly, yes.
And this glaring issue of systemic bias leads us directly into the final, most complex, and undeniably the most culturally contentious aspect of this clinical review.
How society, at a macro level, interacts with this diagnosis.
Exactly. The source material presents a fascinating sociological paradox right at the center of the controversy: the simultaneous reality of overdiagnosis and underdiagnosis.
It seems contradictory, but it makes perfect sense when you segment the population. The intense fears of overdiagnosis are driven by several factors.
Like the broadened DSM-5 criteria we talked about.
Right, plus aggressive direct-to-consumer marketing by telehealth pharmaceutical companies and significant clinician bias. For example, the well-documented phenomenon of diagnosing the youngest, least mature child in a kindergarten class with ADHD simply because they act younger than their peers.
So there is a valid sociological concern that we are pathologizing and medicating standard developmental immaturity.
Yes, yet simultaneously, epidemiological experts estimate that up to 75% to 80% of adult ADHD cases in the United States remain completely undiagnosed and untreated.
So the total volume of diagnoses isn't necessarily the problem. It is the wildly inaccurate distribution of those diagnoses. And those distribution disparities become sharpest and most damaging when we examine gender and race. Let's look at the gender disparity first. Why are girls consistently diagnosed years, if not decades, later than boys?
The review points to two primary drivers. First, the clinical presentation differs. Girls are statistically much more likely to exhibit the predominantly inattentive subtype.
So they are not the hyperactive boys disrupting the classroom and demanding the teacher's attention.
No, they are sitting quietly at their desks, staring blankly out the window, internally disorganized and quietly failing. The medical system, historically, only reacts to the squeaky wheel.
And the second driver?
More profoundly, girls are subjected to intense societal conditioning that demands high social compliance, forcing them to develop sophisticated symptom masking techniques.
Think about the psychological toll of that masking. Imagine the sheer, crushing exhaustion of spending every single day, from childhood into adulthood, manually forcing your brain to simulate neurotypical behavior.
It's completely draining.
Smiling and nodding in a meeting when your working memory has completely dropped the thread of the conversation. Manically organizing your physical workspace while your internal thoughts are in absolute chaos, purely out of terror that you will be judged as disorganized or inadequate.
It is a recipe for severe clinical burnout. This is precisely why we see a massive spike in women finally receiving accurate ADHD diagnoses in their late 20s and 30s. The compensatory masking mechanisms, the anxiety-driven perfectionism, finally collapse under the compounding weight of adult occupational and familial responsibilities.
But while the gender disparities are rooted in clinical presentation, the racial and ethnic disparities outlined in the text expose a deeply systemic flaw in how symptoms are interpreted. And before we dive into this, I want to make something very clear to the listener.
This is an important distinction.
The clinical review highlights deeply politically charged issues regarding race, the justice system, and pharmaceutical ethics. We are not taking a side here, but simply imparting what the source material explicitly outlines regarding these societal impacts.
Absolutely. The clinical review states clearly that people of color, specifically Black and Latino individuals, are significantly less likely to receive an accurate ADHD diagnosis and pharmacological treatment.
Despite exhibiting the exact same symptom prevalence rates as white populations.
Exactly. The neurobiology doesn't change based on race, but the clinical interpretation of the outward behavior is heavily filtered through systemic bias.
How does that play out in a real-world setting?
When a white child exhibits severe impulsivity and emotional dysregulation in a classroom, it is frequently viewed through a medicalized lens. As a neurodevelopmental condition requiring therapeutic intervention and an IEP.
But for a Black or Latino child?
When a Black or Latino child exhibits the exact identical impulsivity, it is disproportionately interpreted through a punitive lens. It's viewed as oppositional defiance, aggression, or a fundamental behavioral failure requiring disciplinary action.
And the document draws a direct, devastating line from that biased clinical interpretation to what it refers to as the misdiagnosis to prison pipeline.
It is a tragic societal failure. When profound neurodevelopmental deficits, impulse control, emotional regulation, and working memory are repeatedly met with punitive suspensions, rather than dopaminergic treatment and behavioral scaffolding, the individual is slowly pushed out of the educational system.
And the untreated impulsivity eventually intersects with law enforcement.
Yes. The review highlights the drastically disproportionate prevalence of unmanaged, undiagnosed neurodevelopmental conditions within the juvenile and adult criminal justice systems. We're essentially criminalizing the underlying biology.
The review pushes even further into the sociological implications, raising a profound ethical question regarding the medicalization of childhood.
Bioethicists cited in the review ask us to critically examine our ultimate motives for treatment. When a clinician prescribes a powerful psychostimulant to a 7-year-old child, are we truly medicating the child to help them actualize their unique internal potential?
Or are we utilizing neurochemistry as an instrument of social control?
Exactly. Are we medicating the child to force compliance within an overcrowded, underfunded, unnaturally sedentary educational environment?
Are we treating a pathology within the child's brain, or are we treating the modern environment's total inability to accommodate neurodiversity?
It's a heavy question.
It forces us to ask if we are artificially suppressing the natural, energetic variance of human development just to keep the assembly line moving smoothly. We have covered an immense expanse of territory today in this deep dive.
We really went from the micro to the macro.
We did. We traced the historical evolution from the accidental discoveries of the 1930s to the neurodevelopmental validations of the DSM-5. We mapped the microscopic reality of delayed cortical myelination and dopamine transporter dysregulation.
We navigated the treacherous overlaps with bipolar disorder, the crucial necessity of metacognitive scaffolding, and confronted the deep systemic biases that dictate who receives care and who receives punishment.
It is a condition that defies simple categorization. It demands rigorous clinical nuance at the synaptic level and profound empathy at the societal level. I want to leave you with one final thought today, something to explore on your own that builds on this entire intricate picture we've painted.
I think the listener has a lot to mull over.
If ADHD is, at its core, a severe mismatch between a uniquely wired, structurally distinct brain and a rigidly structured, aggressively distraction-heavy modern environment, like essentially, imagine for a moment a future society architected differently.
What would that look like?
In a world that evolved to prioritize dynamic, fast-paced, exploratory problem-solving over sitting perfectly still at a glowing screen for 8 uninterrupted hours, would this neurobiological profile even be classified as a disorder at all? Or would it simply be recognized as a different, highly specialized, and incredibly valuable way of being human? Something to think about. Until next time, remember that the X-ray machine almost never tells the whole story. You have to be willing to wade into the murky waters to find the actual truth. Keep diving deep.
Concierge Care, providing world-class, personalized care for patients and members. Taking a proactive approach by offering its free digital health clinic for anyone in need of these services. Reach out to us via our website, www.health.conciergecare.net, or give us a phone call at 786-809-2345.